Welcome to SCAI's Conversations in Interventional Cardiology. I'm Elazer R. Edelman. I'm the Edward J. Poitras Professor in Medical Engineering and Science at MIT. I'm also Professor of Medicine at Harvard Medical School and a cardiac intensive care cardiologist. And with Professor Yannis Testisas, we had the honor of guest editing JSCAI's special issue on the role of artificial intelligence in cardiovascular intervention. Today, we're here to discuss a number of important papers published in SCAI's special issue related to the impact of AI in congenital heart disease. It's been said that children are our greatest underrepresented population in medicine, with the most to benefit and least access and attention. I'm joined by an esteemed panel of leaders and experts, authors of two very important papers in this special issue. Michael Taylor is the Director of Non-Invasive Imaging at the Texas Center for Pediatric and Congenital Heart Disease at the University of Texas at Austin, Dell Medical School in Austin. And Brian Quinn is Assistant Professor of Pediatrics at Harvard Medical School and Associate Cardiologist in the Department of Cardiology at Boston's Children's Hospital. And Kathy Jenkins is Professor of Pediatrics at Harvard Medical School and the Coburn Chair for Patient Safety and Quality. We'll hear first from Dr. Taylor, whose paper, Role of AI in Congenital Heart Disease and Intervention, will appear in our issue. Dr. Taylor.
Good evening. Thanks for the opportunity. So our paper is a review looking at the impact of AI and some very specific applications in congenital heart disease. We looked at its application in imaging, which is already quite impressive, electrophysiology, cardiac catheterization, and finally, looking at physiologic signals in the CVICU and the floor and the cardiology floor. We wanted to highlight how little research had been done in congenital heart disease relative to the adult population. As you can see in this slide, which is the central illustration from our paper, the growth in the adult publication in machine learning was something like 3,500% compared to that in pediatrics and congenital heart disease, which 1,450%, which is still quite a lot, but just pales in comparison to the overall growth in cardiology. So we think as pediatric cardiologists that there's a huge opportunity here. Specifically in imaging, so both in echocardiography, cardiac MR, and cardiac CT, where we have harnessed some of what's been done in the adult world to use for our purposes, but we've also developed unique applications. Probably the most powerful one in looking at image segmentation and cardiac MR. Electrophysiology is a natural application for machine learning. Dr. L. Bokel, who is a former fellow at Boston Children's Hospital, has several publications looking at how impactful machine learning can be for both diagnosis and prognosis. And finally, we have several applications at our hospital and using machine learning for analysis of physiologic signals from the unit. This has been the great hope for machine learning, that we could use it for event detection and especially early diagnosis. And I think much work has gone in. I think the application is still challenging, and we probably still haven't seen the clinical applicability that we would like. But I do think this is the one of the natural applications for machine learning in what we do.
So thank you very much. These data are fascinating. Are there special cases where AI, machine learning, has already shown tremendous benefit? And are there cases where you see the barriers getting in the way, in particular for congenital heart disease?
Sure. So I think for me as an imager, I think the most impressive application for machine learning is actually using machine learning for the analysis essentially of the ventricular volumes and function in patients after the Fontan circulation, but in a giant multi-institutional study of close to 4,000 patients from wide variety of institutions and different scanners and different image quality, but with really sophisticated machine learning, the ability to do the analysis completely automated with essentially no manual oversight, which it would have been impossible 10 years ago to do this kind of volume work without machine learning. Now it's taken a while, but I think it right now represents the most impressive application of machine learning in congenital heart disease imaging for sure. Where the application with barriers. So we, as a field, have tried to apply it to diagnosis of imaging. So just let's take fetal echo, for instance, just using machine learning to make fetal echo diagnoses. So you can imagine trying to extend fetal echo to someplace that might not have the experts that we have in some of our big centers, and how useful that would be. Unfortunately, it has proven to be extremely difficult to get either straight up machine learning or or even a specific deep learning algorithm that can accurately make diagnoses because it's so complicated to get the imaging to be able to train these models where you would consider accurate diagnostic studies.
Well, that's a wonderful lead-in then to our discussion with Dr. Quinn, who will present his paper with Dr. Jenkins, Generating Risk Reduction Analytics in Complex Cardiac Care Environments, Risk Prediction in Congenital. So, Dr. Quinn.
All right, so I just want to say thank you to the editorial team of JSCAI to give us this opportunity to present our work. We're really excited about this recent effort for applying AI-driven risk prediction methodology to congenital cardiac catheterization. This is our GRACE project. This is generating risk reduction analytics in complex cardiac care environments, where we developed a novel risk prediction tool using AI machine learning algorithms in congenital cardiac catheterization. This is a project really that truly would not have been possible without close collaboration with a team of clinical experts, not just at Boston Children's Hospital, but also data science expertise with MITRE Corporation. For those of you that don't know, MITRE is a not-for-profit organization that operates federally funded research and development centers, and they have a team of data scientists that we partnered with in part with a CRICO grant to really support the research that we were doing. From the outset of this project, we recognized that developing a robust predictive model for we termed clinically meaningful adverse events after congenital cardiac catheterization really required more than just clinical insight. It really demanded advanced machine learning capabilities that really went beyond our internal expertise in our clinician understanding. And that's really where MITRE's contributions and their team of data science expertise kind of came in. They contributed with model development and feature engineering, utilizing our clinical expertise, and that collaboration was really something that allowed what was a vision to develop into a rigorous data-driven tool. This is the central illustration here that we provided as part of this manuscript, which kind of gives you a broad overview of the project. We analyzed over 1,400 cases during the study period that we presented in the manuscript, and really utilized a diverse patient cohort. And to really accomplish this, we had to integrate clinical, procedural, and even system-level data across various platforms. This included electronic medical record system, our local heart center cath database structure, and even specific CAT-specific registry. So we took our specific registry work that we're doing with the Congenital Cardiac Catheterization Project on Outcomes, or C3PO, impact data, and we pulled it with our EMR system to really create a very large database to accomplish this. We also pulled in very procedural specific hemodynamic variables, so variables that are obtained during the catheterization that allowed us to pull that into model building. When we looked into these variables in a little bit more detail, certainly we've looked in our field, we used other kind of retrospective analysis where we looked at different patient and procedural characteristics, but this kind of really allowed us to take it a step further. We looked at common variables such as age and weight, specific genetic syndromes, and non-cardiac problems. But because of the application of AI, we were really able to expand upon that. So we looked at very complex definitions of single and two ventricle circulation. That prior work with just kind of standard traditional statistical methodology we would have really struggled with bringing into a model. Other things that we pulled into was something that we termed a pre-procedure cardiac status variable. This was a really important variable that we pulled into our model. This is something that summarizes a patient's physiologic vulnerabilities, utilizing things such as oxygen saturation measurements, estimates of right ventricular pressure, things that you would get in the pre-procedural setting from an echocardiogram, an oxygen saturation measurement, and started pulling that into our data set. Other things that we're able to look at that we really never utilized before in other kind of pre-procedural risk assessment work were things like laboratory values, hemoglobin Z-score calculations. And obviously we looked at procedural characteristics, case type, and procedural risk categories, which are obviously going to be very important in our field in a procedural risk prediction model. And then really kind of taking it a step further, things that we never started to look at before, beyond just patient level data, we incorporated system level features to evaluate the impact of resource strain and how that impacted risk. System characteristics that we looked at include the severity of recent adverse events in the cath lab. So if we had adverse events that occurred in our kind of multi-cath lab unit, how did that impact the risk of the next patient that was going on? What was the cardiac ICU census? How did other operational resource strain in the hospital impact patients who are coming down to the cath lab? So these were factors that, to my understanding, was the first time in our field that we were able to ever look at that to predict risk and how that impacted a patient. By looking at the broader hospital system, we looked at things such as staff ratios, acuity on the ward, and pulled all of that in to capture risk. And this approach really helped us to kind of better understand how environmental factors may elevate an individual patient's risk and impact the healthcare system's ability to anticipate and mitigate complications. And that's really important from my standpoint in a procedural setting, because certainly adverse events will occur in our field. It is certainly a high-risk field, but the ability to mitigate risk in the pre-procedural setting and then be able to respond to a complication and utilize appropriate resources and have those available is going to be hugely important. And that's what the model and the application of these AI algorithms allowed us to do that we were really never able to do before. And, as I mentioned before, the final result after utilizing this was the development of a machine learning model that allowed us to predict what we termed was clinically meaningful adverse events. So we didn't just look at just any adverse event or any minor complication that would occur. We really looked at moderate to catastrophic adverse events. So things that really impacted a patient's clinical status was really important to us. So really looking at really the most highest severity adverse events and complications and trying to predict those so that we can improve patient outcomes. We also looked at multiple approaches to machine learning, and that was certainly a teaching point for myself. We looked at random forest, lasso regression techniques, and these models really shift us from our traditional risk prediction techniques to ones that leverage comprehensive metadata. And this data set was built upon, multiple sources, as I mentioned before, to really identify both direct and indirect contributors to procedural risk. And one of the most important aspects of doing this and going through this process is not only did we build this model, but we're ultimately able to fully implement it in our clinical environment. So this allowed us at that point to inform pre-procedural planning, use team-based decision-making to improve patient care on a day-to-day basis for every patient that came into our cath lab. Certainly, ongoing refinements, broader validation are certainly necessary moving forward. But we believe that this work really lays the foundation for future multi-center collaboration in AI-based risk prediction. And I think this project really kind of highlights not just starting the foundation for looking at these things and going through this experience, but starting to develop a framework to look at this in a multi-institutional setting and collaborating with other centers to really build upon this experience. This is a clinician-led model that is led by bedside experience, but certainly, as I mentioned before, we could not have done it without a dedicated team of data scientists, and that collaboration was hugely important for us to accomplish this, not just develop the model, but also to fully implement that in our clinical setting. Certainly, I think what we were able to do here was certainly laying the foundation for next steps in AI and at least congenital cardiac care.
Well, thank you very much, Dr. Quinn. Dr. Jenkins, you've taught us so much over your career as to how technology and societal issues come together to impact health around the world. With that incredible perspective and legacy, how do you view AI now in the future, not just in the immediate care and diagnosis, but in general for public safety, public policy, the various things you'd like to implement?
Thank you for just, asking for my perspective. There's a lot to say there. In terms of the world, the pediatric congenital heart disease, kind of the world's eye view, one of the really sad things is that only 10% of children in the world have any meaningful access to congenital heart disease care. And so that's definitely something, that we need to change. And I think one of the very first applications of AI, in fact, it's already starting in Peru and in lots of other places, is using AI to expand the clinical workforce so that you can use technology, where there aren't really trained observers or cardiologists and the like, to find the children and bring them into care. And I'm really excited about that. And you really just need to get to the point where you have a high enough suspicion that a child has serious heart disease to be able to have them transfer hundreds of miles in a poor country, for example. If you then flip to the complete other side of it, I actually think that what Brian showed, is really pretty amazing. We really want. I was a former chief safety and quality officer at Boston Children's for many years. And so I know really well that the whole environment, bad things are going to happen in hospital settings, especially in complex, high-risk places like the pediatric cardiac cath lab. But if we can mitigate those risks and we can bring safety to the bedside and rescue patients, they'll be okay. And our ability to really see that broad view and have those resources ready for the patients who need it, and use, technology and data that we already have, that's really important. And although in this paper, we really didn't find those really key system variables that we could get easily into these models, certainly not in real time, they are there. They are there. And when the hospital's very busy and there aren't enough anesthesiologists or extra people to come if we need help, that's a vulnerability. And that's not something the people right at the bedside can see. They need that broader view. They need technology to help. And so I'm super excited, to see that technology being deployed, right for my own patients when they're going through these risky procedures, as some of them did today. So I think, both sides of that, and we're in a really good place. And I want to thank your journal for really highlighting, the use of this new technology.
Well, we want to thank all three of you and give you 30 seconds to sum up what you think the future will hold for AI and congenital disease. Dr. Taylor?
Yeah, I think the biggest impact for AI and congenital heart disease is going to be exactly what Dr. Jenkins just said, is it's going to allow us to extend our coverage to places that don't have it. Echo is a great example. You can now use machine learning based technologies to allow Echo for people who have no idea what they're doing to be able to get images of children in underserved countries and hopefully bring them to care sooner than they otherwise would be.
Dr. Quinn?
Yeah, certainly as a proceduralist, I think of risk, and in pediatrics and congenital heart disease, obviously our patients are very heterogeneous, and it makes studying them and predicting risk quite challenging. I think AI has allowed us to look at nonlinear variables and better understand and evaluate the heterogeneity in this population to understand, predict risk, and allow resources necessary to mitigate these risks for these patients and improve our outcomes in not just the cath lab, but in other procedural settings as well.
Dr. Jenkins, final word.
Yeah, I think that it's also going to help us deal with the enormous, diversity and complexity and just how rare some lesions are. It's going to allow kind of the world's, we can share the data across the world for these rare problems. We can all benefit from each other and really, really learn from every single patient that we take care of.
So with that, I want to thank our speakers, Doctors Taylor, Quinn, and Jenkins, and in particular, the inspired leadership of SCAI, Dr. Alexandra Lansky, and my co-guest editor, Dr. Shastis. So with that, thank you for joining us, and again, thank you to all.